Hello, everyone. I'd like to extend a warm welcome to all of you today, and thank you for joining Heart and Stroke Foundation's webinar in collaboration with HeartLife Foundation. We want to acknowledge this very important week as it is Heart Failure Awareness Week. The Canadian Heart Failure Society, together with partner organizations, including Heart and Stroke and HeartLife Foundation, are leading the 6th annual National Heart Failure Awareness Week campaign to raise awareness, increase public knowledge, and also to provide a better understanding of heart failure. My name is Shannon Doucette, and I am the Heart Failure Project Lead at the Heart and Stroke Foundation, and I'm also honored today to be one of your moderators and panelists today. And we now would like to begin by acknowledging the Indigenous peoples of all the lands that we're on today. While we're on a virtual platform, I would like to take a moment to acknowledge the importance of the land which we call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this nation home. As we gather today because of a shared commitment to equity, including health equity and reconciliation, I encourage you to reflect on what that means for you in your work and also in your lives. I would now like to introduce you to our second moderator and panelist, Dr. Jillian Code, a person with lived experience and co-founder of HeartLife Foundation, who will be introducing you to our incredible speakers today. Over to you, Jillian.
Thank you, Shannon. Hello, everyone. As Shannon said, my name is Dr. Jillian Code. I am a person with lived experience of heart failure and two-time transplant recipient. And I'm co-founder along with Mark Baines of the HeartLife Foundation of Canada. Mark is also co-lead for the Canadian Heart Function Alliance, which is a national network of heart failure, of heart function research. Next slide, please. Our next two panelists, I'm really honored to welcome today, is Dr. Rahul Jain. He is an academic physician and hospitalist at Sunnybrook Health Sciences Center and an assistant professor in the Department of Family and Community Medicine at the University of Toronto. He is actively involved in the development of clinical practice guidelines, knowledge translation tools, and advocacy initiatives related to heart failure. And he is passionate about translating evidence into clinical practice to prevent and manage cardiovascular conditions. And you're going to hear all about that today, I know. And our second incredible speaker that I have the honor to introduce is Dido Devlin. Dido Devlin is a person with lived experience, an administrator for the University of King's College Writing and Publishing Program in Halifax. Dido is a 54-year-old single mother of two amazing young adults, currently living and working in Halifax, Nova Scotia with her 7-year-old Abyssinian cat, Gus. She has spent most of her working life in the affordable housing sector. However, since her heart failure diagnosis in 2020, she now works, as I mentioned, as an administrator for University of King's College Writing and Publishing Program. She has completed many courses in improvisational comedy. I knew I would stumble over that, too many syllables, stand-up and sketch comedy writing, and looks forward to embarrassing her kids for at least another decade or as long as her heart holds out. And I hope that's, I know it's going to be a very long time. And so first up is, coming up next soon. Our session today is on heart failure for Heart Failure Awareness Week. And as you may be aware, heart failure is one of the fastest growing cardiovascular conditions in the world, with more than 100,000 Canadians this year alone will be diagnosed, adding to the nearly 800,000 Canadians currently living with heart failure. Heart failure is a leading cause of hospitalizations with the highest rate of hospital readmissions in Canada. And we know that it places a significant burden on people with lived experience, their families and caregivers, impacting the lives of 1 in every 3 people in Canada. So as part of Heart Failure Awareness Week, we are really stating that these numbers, demand action, and it is our mission to work collaboratively toward a common goal of improving the lives of people in Canada with heart failure. Next slide, please. Thank you. During this program, you will be able to understand, these are our objectives here: describe the early symptoms, signs and symptoms of heart failure, discuss the strategies and tools that primary healthcare professionals to recognize and diagnose heart failure. You'll gain a perspective on the heart failure story from a person with lived experience, and we will discuss opportunities to improve health outcomes for people with lived experience with heart failure through a better understanding of the warning signs and earlier diagnosis in the community. So what we would like to do now is explore a greater understanding of the signs and symptoms of heart failure and some strategies and tools for primary care professionals in recognizing heart failure. So with that, I have the honor to welcome Dr. Rahul Jain. Doctor?
Thanks so much, Jillian, and good afternoon to everyone. And special thanks to the Heart and Stroke and HeartLife Foundation for inviting me to present today on heart failure, which unfortunately is a growing epidemic in Canada. I have no financial disclosures. So heart failure is a chronic condition. That means the heart is not functioning as it should. So there may be a problem with its structure, and the heart may be too weak, too stiff, or even both. So think of the heart as a pump. When it's healthy, it pumps oxygen-rich blood efficiently to the rest of the body. However, in heart failure, this pump doesn't work as well as it should. There's impaired flow of blood out of the heart, which we refer to as reduced cardiac output. And as a result, blood and fluid may back pressure and end up in the lungs, the belly, and the feet. Also, a number of what we call maladaptive hormonal reactions occur in the body, causing narrowing of blood vessels, resulting in restricted blood flow, fluid retention, and anatomical changes in the heart. So what are the signs and symptoms of heart failure? So as a brief overview, kind of med school 101, a sign is an objective finding that can be seen or measured. So for example, we could see that a person has swelling in their feet, or objectively measuring weight gain. But a symptom is subjective. So this is only what's perceived by the patient. So a person may describe feeling fatigued or breathless. So heart failure is really what we call a clinical syndrome, characterized by a constellation of signs and symptoms. And these can include shortness of breath, feeling tired and low energy, increased swelling in the feet, ankles, leg, and stomach, a persistent cough, especially when people lie down, or sudden weight gain, which could be attributed to fluid retention. So it's not uncommon to see patients present to our clinic or the emergency room mentioning that they can only sleep by sitting up in a chair or propped up on multiple pillows, as they would feel breathless if they lied flat. And this is a symptom we call orthopnea, which may be related to fluid in the lungs from heart failure. So some of the risk factors for heart failure include aging. People are living longer with other conditions that can lead to heart failure over time. Coronary artery disease, a heart attack from clogged arteries can lead to damage and weakening of the heart muscle. High blood pressure, if the heart has to constantly push blood against such high pressure, this can lead to stiffening of the heart muscle. And diabetes. And as a result, heart failure can be caused by one or more of these factors, such as coronary artery disease, left ventricular hypertrophy, which is really thickening of the heart, often due to hypertension, heart valve problems, or problems with the heart rhythm, such as atrial fibrillation. There are also other possible causes of heart failure, including genetic reasons and exposure to toxic agents, such as certain chemotherapy agents, or even excessive alcohol intake. So how do we screen for heart failure? So when heart failure is suspected, a diagnosis should be confirmed by assessing for signs and symptoms of heart failure, which we just discussed, and then corroborating it with at least one additional diagnostic test. And this could include a chest X-ray, where you might see features like increased size of the heart or fluid within the lungs. We could obtain an echocardiogram, which is an ultrasound of the heart, looking at its structure and function. And now there's some newer blood tests called BNP or NT-proBNP that measures natriuretic peptides, which become elevated in heart failure due to changes in pressure in the heart. So once a heart failure diagnosis is confirmed, it's important to determine the heart failure type based on ejection fraction, which I'll talk about in a bit, and symptom severity to inform management approach, and determining underlying causes to guide subsequent treatments. So for patients with heart failure, confirmed heart failure, we would use an echocardiogram to determine heart failure type by ejection fraction. Now, the ejection fraction measures how well the heart pumps out blood with each heartbeat. So a normal ejection fraction is typically between 50% and 70%, which effectively means that the heart is pumping out more than half of the blood in the left ventricle with each heartbeat. We describe heart failure with reduced ejection fraction as being less than or equal to 40%, mid-range 41 to 49%, and preserved heart failure as greater than or equal to 50%. Now, this classification of heart failure based on the ejection fraction is so important since it helps guide treatment recommendations. So this new treatment algorithm, or what we call guideline-directed medical therapy for people living with heart failure with reduced ejection fraction, was published by the Canadian Cardiovascular Society in 2021. And as noted in the red circle at the top, the 4 pillars of heart failure with reduced ejection fraction management includes the use of what's known as the Fantastic Four, 4 medications that have been shown to reduce mortality, reduce hospitalizations, and improve symptoms from heart failure. So these 4 agents include an ARNI or an ACE or ARB, a beta blocker, a mineral corticoid receptor antagonist or MRA, and an SGLT2 inhibitor. And as we work down the algorithm, the recommendations become more individualized to the patient. Now, if we look at heart failure for mid-range and preserved ejection fraction, we'll be having more guidance on management strategies in the near future, although for now, we continue to ensure good blood pressure control and management of fluid retention. So this slide highlights some of the lifestyle measures we suggest for people living with heart failure. Although there is limited evidence, reducing salt and fluid intake can be important, given that fluid retention is often a hallmark of heart failure. We encourage regular physical activity, and I highly recommend referrals to local cardiac rehabilitation centers for one-on-one education. As with cardiovascular health in general, smoking cessation and limiting alcohol intake should also be encouraged. So when it comes to monitoring, patients should see their healthcare provider, including their family doctor, regularly for comprehensive visits. An important element of self-management is encouraging people living with heart failure to weigh themselves every morning. And we usually recommend doing it at the same time, so after voiding and before breakfast, and report to their healthcare provider if they notice weight increases of more than 2 pounds in 24 hours or 5 pounds in a week. We often provide what we call sliding scale diuretic doses, whereby patients can self-titrate their diuretic dose based on their daily weight. Now at the bottom, with respect to warning signs and symptoms of worsening heart failure, in the yellow box, you'll see situations where patients should contact their healthcare provider for advice, such as increased swelling in the feet or weight gain. And in the red box on the right are situations where patients should proceed to the emergency room. And these are what we call red flags, such as chest pain, shortness of breath, even at rest, or fainting. So just a few words about some challenges and opportunities from a primary care perspective and healthcare provider. So we know heart failure is often referred to as a revolving door condition. And this is the case because after a person with heart failure is discharged, 1 in 5 of them are readmitted to hospital within just a month. And we know heart failure will soon cost Canada more than $2.8 billion a year, given that it's a growing epidemic. So where are the opportunities? We'll be learning more about advocacy efforts in the webinar today, But I strongly feel there's an opportunity to improve care across the continuum by ensuring more seamless coordination of care among care providers and during transitions of care when patients move from hospital back into the community. And we also know that not all Canadians have equal access to important diagnostic tests and specialized care. So there's an opportunity to improve by closing the care and treatment gap. So just to conclude with some key messages, heart failure is a chronic, incurable at present, and on the rise. It's important to recognize the common signs and symptoms of heart failure early so people can seek medical attention before their condition worsens. With early diagnosis, lifestyle changes, and proper management, people living with heart failure can have a good quality of life. Taking charge of mental health through personal strategies, support groups, and counseling is also very important. So in the words of Dr. Ducharme, we need to work as a team, and patients and caregivers are an integral part of the team. It's the only way we're going to succeed. So thank you, everyone, for listening, and back to you, Jillian.
Thank you, Dr. Jen. That was a very illuminating presentation, and I really love that last quote from Dr. Ducharme. Indeed, is that we do need to work as a team, and the primary care provider, in my opinion, and many people's opinion, is actually the quarterback on that team. And so we're extremely grateful for you and your insights, and we look forward to hopefully having some time for questions later on. So thank you so much.
Thanks, Julian.
So now I'd like to turn it over to Dido Devlin to speak to her experience. Dido?
Hi there, and good afternoon, everyone. I have to admit that it's a little humbling to start this presentation after having included in my bio that I've done a lot of work in comedy, because this isn't particularly funny. My journey hasn't been particularly funny, and the balance of this presentation isn't probably going to be particularly funny. However, I will start out by saying that I don't like to talk about my quote-unquote heart failure journey, because to my mind, if this had been a journey, it would have been a really horrible one, not unlike taking a milk run bus trip across Canada next to the bathroom at the back of the bus. So that would be the quality of the journey that I've had. So instead, I prefer to talk about my heart failure story. And also I work with writers all the time. So I like to think of it within the context of a story within a story. So my story really begins within the context of my diagnosis. My diagnosis for heart failure came about as a result of my cancer. And everybody really has a different story. My diagnosis also happened within the context of a healthcare crisis and within the more specific context of a pandemic. So this is my story. Again, it's a breast cancer story, and that turns into a heart failure story inside of a healthcare crisis and inside of a pandemic. That's why the babushkas are there. But let's back up and start at the start. That's always the best place to start. The writers tell me. So all the way back in March of 2013, I was living in Ottawa, and I was diagnosed with HER2 positive breast cancer. Came out of the blue, shocked and surprised, but I had an amazing oncology team, and my treatment consisted of mastectomy, double mastectomy, and 4 rounds of chemotherapy, and then a year of Herceptin treatments that happened once every 3 weeks, I think it was. As a result of all of my treatments, I was followed pretty closely by cardiac oncology, because there's a known correlation between these treatments and decreased heart function, as the doctor mentioned in the previous presentation. Between 2013 and 2018, my cardiologist noticed that my heart function had decreased to what was called low normal. And around that same time, I decided to move home to Nova Scotia. I'd spent 25 years in Ontario, and I'd weathered the storm of raising 2 kids on my own and going through breast cancer, and I thought it was time to go home. And I was told that I needed to connect with a cardiologist as soon as I got settled back in Nova Scotia. And that is what I tried to do. I'm sure most people are aware that Nova Scotia, not unlike many other provinces in Canada, have wait lists for healthcare professionals. I moved home in November of 2018, and in early 2019, I managed to find a nurse practitioner and asked that they refer me immediately to cardiac oncology, and they did. I checked in regularly with my nurse practitioner to see if they had heard anything back from the health authority, but nothing. There was just silence. So I kept on keeping on. I was working, I was volunteering, I was not necessarily living my best life because I wasn't feeling all that great, but I was moving forward. Through 2019 and into 2020, and we all remember 2020, I was working hard. At the time, I was working in the affordable housing sector, and I was getting tired, and I was getting more tired. And this was generally explained to me as I'd gone through cancer. I probably had what they call chemo fog, some cognitive fog from the chemotherapy and maybe the Herceptin treatment. And I was newly menopausal, so I was bound to be tired. And it was not unusual that I'd had some weight gain as well. The pandemic hit, my work in the housing sector became more challenging, and I became more tired. My nurse practitioner noticed over time that my blood pressure had gone up. We didn't think it was time for medication yet. We also decided that I was depressed. Not unusual. It was a pandemic, and I was working in the affordable housing sector. There was a lot to be depressed about. I gained more weight, and I was more tired. And there was still no response to the cardiology referral. She sent a couple of follow-ups to the health authority. Finally, in October of 2020, I just couldn't breathe. I felt like I was drowning, and I called 911. It was about 11 o'clock on a Sunday night after the Thanksgiving weekend, and I just couldn't breathe and knew something was very, very wrong. I called 911, and when the EMTs arrived, two nice young individuals showed up, and they encouraged me to sit on the curb and take a moment, and encouraged me and to calm down, and told me that I was having a panic attack. So I sat on the curb, and I continued to struggle to breathe. And I finally eventually convinced them to let me into the ambulance, but only after sort of gasping for air for a while and having to convince them. They really didn't want to let me into the ambulance because I also had a cough, and they thought I had COVID. And so they told me that if I had COVID, they'd have to completely sanitize the inside of the ambulance afterwards. They did finally let me into the ambulance, and they took me to the ER. And within 15 minutes of getting to the ER, a doctor scanned my chest and told me that I was in heart failure. My heart function, my ejection fraction was at 8%, which is incredibly low. I was in the hospital for a week, and just getting stabilized on medication and having everyone take a look at me and do all the tests. But what really stuck with me was the fact that every cardiologist that came through on rounds to see me that week basically said some version of, "You should have seen a cardiologist. You've been really reckless with your health. How do you avoid the signs? Why do you ignore the signs? You must have had incredible swelling in your feet. You must have had a huge weight gain. Why didn't you seek help?" And to say that I was frustrated by those comments is, difficult. Next slide, please. Maybe some helpful hints and insights here. My experience of being diagnosed and treated for and recovering from heart failure during the pandemic was incredibly lonely and isolating and disconnected. During that time, I was put on a number of medications and was told that we would wait and see what happened and see how my heart function progressed. I was followed by the heart function clinic for 1 appointment a month for about 6 appointments. Between the time I was diagnosed in October of 2020 and August of 2021, I had 6 appointments. And just before my final appointment, I had an internal defibrillator implanted in my chest that would restart my heart in case of cardiac arrest. And I went back to the heart failure clinic afterwards for a follow-up and was told, "Congratulations, you must be really thrilled. You're being discharged from the clinic today. This is your final appointment." And I was stunned. because I had only attended 6 appointments and seen a cardiologist a couple of times. I'd received no patient education and no real sense of my prognosis with heart failure. And I was being discharged from the heart function clinic. I wasn't thrilled to be discharged. There was also no cardiac rehab. All of that had been shut down during COVID. There was no referral to a dietitian. That was shut down due to COVID. And I'm not sure if there had been patient education previously. So about 10 months after my diagnosis, I had an internal defibrillator, 6 medications, and no one to talk to. I had zero sense of how long my runway was. I knew that 8% ejection fraction was not good. And I unfortunately looked at the internet to see what the internet had to say about my prognosis, and that really wasn't good, but I knew enough to know that that was probably artificially dire. So I ended up taking 18 months off of work after my diagnosis because I just wasn't well enough mentally or physically to keep working, and I needed time to try and recover as best as I could. So I was alone, I was lonely, and I was like the little astronaut floating in space. But I did have one person on my team who was super helpful, and that was my therapist, Shannon. During one session in early 2021, when I was complaining about all of the uncertainty I had about my heart and my diagnosis and my treatment plan and my low blood pressure, she told me that the healthcare system in Nova Scotia was not going to provide me with the information or support that I needed. It just wasn't, and that I had to look elsewhere. She recommended that instead I look to the Heart and Stroke Foundation website for these things instead. And that's just what I did. And I'm so thankful for her advice. Next slide, please. Her advice led me to connect to other people and to the values that have been important to me throughout my life as an advocate. And the Heart and Stroke Foundation website helped me make connections that I needed to develop some faith in the future for myself. It led me to be with others who had experiences similar to mine, so I didn't feel so alone and so isolated. And it led me to be inspired by cardiology researchers and to learn more about the amazing advancements being made. From the Heart and Stroke website, I learned more about heart failure and found many helpful heart failure resources for myself and my family. I also ended up on the Heart Hub website, the Ted Rogers Center for Heart Research, and eventually that site led me to another hero of mine, Anne Simard, who's a staff scientist at the Ted Rogers Center for Heart Research staff. And that led me to a program called Writing the Heart with Shannon Gray, which was 6 weeks of writing and exploring what it's like to live with heart disease as a woman in Canada. Anne Simard also led me to the Transform HF Trainee Awards for digital innovation for heart failure care, where I've volunteered for the last couple of years reviewing award applications, and also led me to attend the masterclass for patient partners engaging in cardiovascular research in Montreal last October. And that in turn led me to the Canadian Heart Function Alliance, where I'm now working and volunteering to increase awareness of patient partners in cardiac research here in Atlantic Canada. Honestly, I still don't know how long my runway is. Probably it's shorter than I had anticipated it was when I was 35. I've had cancer and I have heart failure, and I continue to have my doubts about the healthcare system in my province. But at least now I have some sense of community. And because of my involvement as a patient partner in research projects, I do get to see firsthand the amazing innovations that are being developed that might just give me a longer runway than I initially imagined. Thanks.
Thank you so much, Dido. What an incredible story you have. It's, I'm actually speechless. That was absolutely incredible. Thank you so much for sharing, and leaving us with a message of hope. And with the advances in treatment now, I really do feel that your runway is probably longer than you think, and so that is really wonderful. I'm just like so many words. I do want to, before I pass it on to Mark and Shannon, I do want to highlight that there is a pattern of healthcare professionals dismissing women's symptoms as anxiety, panic attacks, or some other less serious issues. And the research has shown that this leads to traumatic encounters, delayed or incorrect diagnoses, and often strained relationships with the healthcare system. And so it's really important that we continue to raise this awareness about women and cardiovascular disease. And thank you so much, Dido, for all that you are doing and all of your hard work. So what I'd like to do now is hand it over to Shannon. Sorry, I'm very emotional. It was really amazing to talk about how we exploring the national framework and systems assessment of heart failure. Shannon.
Thank you, Jillian. And in response to this serious and very complex condition and growing trend, there is hope. And we know that Heart and Stroke has been a leader and convener to improve heart failure care across Canada. In partnership with World Heart Federation, we actually hosted the very first National Heart Failure Roundtable, which really brought together people with lived experience and caregivers, some of Canada's leading clinicians and researchers, and health system leaders, and even organizations including HeartLife Foundation, to truly find sustainable and feasible solutions to address issues such as equity in access to heart failure care, and even ensuring optimal outcomes for people living with heart failure across Canada, such as Dido. Heart and Stroke has done an incredible amount of work over the past several years by informing a national heart failure action plan for Canada. And this plan really tackles heart failure at all fronts, and with a goal to achieve equitable and timely access to heart failure care across all provinces and territories, while leveraging collaboration at the national level, including advancing research, preventing heart damage, and also improving diagnosis and access to care and medications. There are 5 main pillars that represent 5 priority themes within the action plan, and where the foundation of the action plan is really just to truly ensure that everything is built upon the needs of people with lived experience with heart failure, for their families, and also for their caregivers. And some of the national initiatives that will inform new and ongoing initiatives as part of Canada's Heart Failure Action Plan include the collaborative consultation approach co-led by Heart and Stroke and HeartLife Foundation that captured the insights into the experiences of people living with heart failure and their caregivers. The areas that are of most urgent, as we've seen in our webinar today, and also priority when it comes to heart failure and equitable access to heart failure care, that we learned include mental health and heart failure, how women specifically are experiencing heart failure and what their needs are specifically, rehabilitation in heart failure, and what having an approach to palliative care means in heart failure, and what the economic impacts of living with heart failure are. And when it comes to economic impacts of living with heart failure, one initiative that will improve the lives of people living with heart failure is the work from our heart failure leaders across Canada in the development of a national heart failure economic analysis. In alignment with the Heart Failure Action Plan, Heart and Stroke recognized it was important to determine 1, the economic burden of heart failure hospitalizations in Canada, and 2, the burden of heart failure drug costs in the elderly in Canada. We have seen that heart failure is a significant burden in our hospital system. We are working with partners to understand the specific gaps and strengths in each system, including a gap in effective management of heart failure in the primary care setting. And lastly, one national initiative that Heart and Stroke has been very instrumental in leading is the Resources and Services Inventory, also known as the RASI. This is a one-of-a-kind data that has painted a picture of how heart failure care is delivered and the services and resources available to people living with heart failure across Canada. For example, despite recommendations of NT-proBNP, so a heart failure screening tool to improve diagnostics accuracy in heart failure, This biomarker testing is not only consistently available across Canada. The RASI highlights significant gaps such as this and geographic variation, but also areas of excellence in the delivery of access to heart failure services across Canada. So each of these national initiatives help really inform provincial and national health systems, governments, and also quality of improvement initiatives. Here we illustrate shared priorities and common themes that have emerged across all provinces that we will tackle together with provincial leaders and champions to carry out the action plan and to make an impact within each province. And now, what does it look like to make an impact and really improve heart failure outcomes from coast to coast to coast? Heart and stroke, and our provincial health systems, leaders and of care have already played a pivotal role in making such an impact. For example, we've had the opportunity in advocating for successfully getting heart failure on some government's radar as a priority, including one acknowledging Heart Failure Awareness Week and bringing awareness at the provincial level, ensuring continued access to heart failure screening BNP testing, a commitment to ongoing funding to support nurse practitioners and pharmacy positions, a cross-pollinating evidence-based pathways and supporting hub and spoke models of care, and also addressing heart function clinics with a goal to expand capacity of heart failure clinics. As we continue to tackle heart failure at all fronts, we acknowledge our partnerships, including HeartLife Foundation, who share a passion and also a framework for change across Canada. Now I have the honor to pass it over to Mark Baines, who will shine the light on HeartLife Foundations and their incredible work. Over to you, Mark.
Thank you so much, Shannon. I really appreciate that. And I mean, the work that your team is doing at Heart and Stroke and with your partners across the country is just going to really create positive change for people living with cardiovascular disease and particularly heart failure. So thank you for that presentation. And it really complements the work that HeartLife is doing right now. And I'm going to discuss a little bit about that work, HeartLife's framework for change. Next slide, please. And so why do we start this framework for change? And, you know, Shannon alluded to, as Dr. Jane alluded to as well, heart failure is a pandemic. And there's almost 800,000 actually people living with heart failure now, 100,000 new diagnoses every year. That number is rising. And the economic cost associated with heart failure will be up to $2.8 billion by 2030. I mean, just think about that. And that's heart failure specific. Unbelievable. Next slide, please. Perfect. Sorry, I just had a note pop up in the corner that said I was speaking French. I'm not. Our framework for change came about through multiple years as well as multiple projects. We first started with the patient journey map to better understand the lived experience perspective in Canada, really what the challenges and opportunities were. And what we found was there was no national standard of care for people living with cardiovascular disease or heart failure. I lived in Metro Vancouver when I was diagnosed. I had access to 3 major centers. I had one of the best cardiologists in the world and an amazing multidisciplinary team. But I was the exception and not the rule. I think about Dido's experience being diagnosed through COVID and the challenges and adversity that Dido had to go through. I didn't have to experience that. My level of care should be the same care that every person in Canada gets. Next slide, please. And so when we developed the framework and the charter, particularly the charter, we utilized it through multiple facets. Through industry, who use it for training purposes for their team when developing medications or technologies to think about equality for patient care. In health system development, when we work with our partners such as Cardiac Services BC or Alberta Health Services or Ontario Core Health, how can these standards of rights be implemented? And then through advocacy as well. Next slide, please. The charter, I mean, was picked up. And so we knew that there was an impact here. It was endorsed by 32 organizations worldwide, translated to 17 different languages, and now had the impact really to help the over 64 million people living with heart failure around the world. But that wasn't enough. Next slide, please. We said, how can we transition this? How can we transform this to policy change? So we developed the Heart Failure Policy Framework, which is a national action plan for heart failure change. Next slide, please. And so what is the framework? Well, we worked with the Institute of Health Economics in Alberta to really quantify the qualitative items in the charter. So when we think about access to care, accurate and timely diagnosis, access to mental health, what does that mean from an economic standpoint? Because when we talk to policymakers and government officials, they're going to ask these questions. How is it going to help the economy? And so we have background data on the health crisis, as I mentioned. We have background data on the economic crisis. So as I mentioned, $2.8 billion by 2030, for instance. We have details on each recommendation. So we talk about diagnosis and screening. Dr. Jan mentioned diagnostic tools such as NT-proBNP and echoes, for instance, providing just readily available access to those blood tests in the community. So GPs, upon presentations of symptoms, can say, hey, go for an NT-proBNP, and if there's signs of heart failure, we can refer you to a specialist. And then we have tools for measuring success of that. How many NT-proBNP tests are issued? How much access is there across the country from coast to coast to coast, for instance? Next slide, please. And we also have funding mechanisms supporting these strategies. So yes, we have the data to say why we're making the recommendations. We have the recommendations themselves, how to measure these recommendations, and then how to fund these recommendations. So really an all-encompassing framework for change. Next slide, please. And we also create a summary just as easy talking points that can be found on our website. And I know our resources will be shared later. Next slide, please. And as we move forward, working with groups like Heart and Stroke, the Canadian Cardiovascular Society, Canadian Heart Failure Society, it really does take a partnership to evolve the strategy in Canada. As Shannon alluded to, when Heart and Stroke held that national roundtable on heart failure, it's really setting the stage so we're not operating in silos. We're all working coherently to develop this pathway for change for people living with heart failure. So we're engaging with multiple stakeholders across the care continuum. And something that HeartLife is looking to do with our partners is really to support legislation around a national strategy for change for heart failure. Next slide, please. In February, we had the opportunity through Senator Martin to actually provide more awareness around heart failure in Canada, this framework, and we'll be doing the same this week in Ottawa on Thursday, where the Senator will speak in the House about our framework for change, the need for heart failure care in Canada, and really a cohesive strategy. Next slide, please. And again, we can't do it alone. As Shannon alluded to, it takes really partnerships to evolve our message. And a part of those partnerships, as Dido said, are patients and caregivers. So we work with patients and caregivers across the country to facilitate our work, but leading key organizations such as ones that were mentioned, Transform HF, Canadian Cardiovascular Society, Heart and Stroke Foundation, to really advance our message. So just know that in Canada, what we're trying to do is really create this coordinated approach to heart failure care to improve the lives of those living with heart failure. Next slide, please. Thank you very much.
Now have this opportunity for a question and answer for a panelist discussion. And I will open up the question for Dr. Jan. You had mentioned that heart failure is an epidemic in Canada. And what do you think heart failure and why do you think heart failure is on the rise in Canada?
Yeah, great question. Thanks, Shannon. So Mark also alluded to this in his presentation. We know heart failure is an epidemic in Canada. We're almost hitting towards 800,000 people living with heart failure and 100,000 being diagnosed each year. So really important. Probably a number of reasons why heart failure is on the rise. We know that there's an aging population. As people live longer, they may develop other risk factors for heart failure. Younger people are being diagnosed. We have better diagnostic tests, risk factors, so we are diagnosing more people. And unfortunately, the COVID-19 virus has also been shown to cause damage to the heart, and this has increased heart failure cases. So I think it's really important that we try our best to screen for and manage risk factors like hypertension and diabetes, which are also on the rise. So a lot of work to be done.
And I have a question. We have a question for Dido. From a person with little experience, what needs to be done from your personal experience to how to move forward and really to improve heart failure care across Canada?
Resources. I think there has to be political will to make sure that governments forward the funding to hire the professionals to make sure that we have enough professionals in the hospitals to look after people. That's at the end of the day, that's really, it's a supply issue. The fact that it seems that we don't have enough actual people in the hospitals looking after our patients. And for me to have waited over 20 months to be referred to cardiology. In fact, the week after I got out of the hospital, after my diagnosis, I received an appointment in the mail, just a slip of paper saying that I was supposed to see the women's cardiology clinic the next week. And I had to contact them and say, thanks, I'm already in your system. I've been in the hospital. So yeah, that's it.
Well, in the lines with the community and the impact within the community and so on, Dr. Jen, there is a comment or a question about what do we think about the diagnosis of heart failure, and it's often delayed or even missed within the community, and what can be done to really truly improve this from a primary care perspective? And we talk about those resources and so on.
Yeah, so I mean, Dido, your story was so powerful, and it just speaks to one of so many that are out there. And I think that with all good intentions, the reasons for delayed or missed heart failure diagnoses are probably very multifactorial. We've seen today that the condition itself is so complex, right? And there's so many signs and symptoms like fatigue and shortness of breath. But these symptoms can also be caused by other conditions like asthma or COPD, which can make the diagnosis challenging. So probably from my perspective, I would say to improve timely diagnosis, we need to act on all fronts. From the patient or person perspective, really learning about and recognizing what are the signs and symptoms of heart failure and seeking out medical attention if you have concerns. As a clinician, I think, it's important that we regularly screen people for risk factors of heart failure, and we think about heart failure as a potential diagnosis. So not, looking at pattern recognition and thinking of other things that might cause it, really putting heart failure at the forefront, knowing how prevalent it is. And at a system level, we raised many points, how can we really improve access to such important diagnostic tests and specialized care that's timely and team-based.
In speaking with having access to appropriate diagnostic testing, we do have a question from our participants, and this is open to everyone, is what types of diagnostic tests can the medical team do to give an idea of heart failure patients' longevity? Dido spoke about the runway, and is there anything that can really help provide whether it's a diagnostic testing or anything for this comment?
Yeah, so maybe I'll try to take a stab at it. So I definitely would reach out to our specialized colleagues too in the heart failure clinics. But, again, predicting prognosis is often very hard, and for any condition, any end stage condition. But what we often look at are patterns, and we look at symptom burden. So we use something called the NYHA class of symptoms, is it mild to severe, and also looking at ejection fraction. And how does this change over time? So by having regular follow-up, we get a better sense of, how is the condition progressing and how do we expect the trajectory to look like? Also thinking about underlying causes, right? If we can identify what may have caused the heart failure, can we intervene on that? Could it be a faulty valve that, we can replace and potentially improve cardiac output? Some patients like Mark and Jillian mentioned, they've been, very fortunate recipients of transplants. These are opportunities that can really be game-changing and change the trajectory of heart failure. But again, as we mentioned, very hard to predict, but it's really looking at the constellation of the symptom burden, ejection fraction, and change over time.
Excellent. And this may be one for Mark or for Jillian. Someone's commented, so Dido's story highlights the importance of access to specialized care. And how can we improve access to care for patients with heart failure or suspected heart failure who's not well connected within the overall healthcare system?
Yeah, sure. I mean, great question.
Mm-hmm.
When we think about heart failure, we always think about the physical challenges with the disease, right? And you often overlook everything else. Heart failure is an invisible disease. I mean, I think if you saw myself, died over Jillian on the street, or we were just joining a conversation, you would not think that we have heart failure. And so, as much as we look at the physical aspect of heart failure, we have to consider the mental and emotional support side of heart failure as well, and ensuring that mental health support is an integral part of the team. And then thinking about team dynamics. So, thinking about the conversations that you're going to have with your family or general practitioner, right? Such as Dr. Jan, who's coordinating the care, thinking about your pharmacists. How are they integrated into your care? When we think about our multidisciplinary care team, pharmacists are often someone that we have the most touch points with, right? And how are they supporting your care and helping you self-manage? Then you think about cardiac rehab, you think about nutrition, and if you have comorbidities, who's managing that entire team there? But it is also taking a lens on the patient themselves, understanding their goals and objectives, and then creating that care pathway and that team around them to ensure every one of their needs is met throughout their continuum of care, because the needs will change as their diagnosis develops.
Thank you. Was there any other last comments that anyone would like to share?
No, I just think, I mean, yeah, I want to thank, Heart and Stroke for the support in helping putting this on, Dr. Jan, Dido, Jillian, Shannon, and the work that's happening collaboratively across the country is really going to set the stage, not just in Canada for heart failure care going forward, but I really do think globally going forward that we're setting the benchmark for really what a gold standard of care for heart failure should be. And we're going to improve outcomes with what we're trying to accomplish. And thank you all again for this. And Dido, thank you so much for sharing your impactful story. Just from the comments here, and I've been scanning Twitter as well. I mean, it really had a positive impact on people. So thank you for that.
Yes, thank you. Well, now I'd like to just move forward with our resources, and I want to thank everyone for your thoughtful questions and answers. We did not have enough time really to truly answer everyone's questions, so if we didn't, we will provide a summary of the questions and answers in a follow-up email. And for further information, resources, and supportive tools, we will invite you to visit the Heart and Stroke site as well as HeartLife site and websites, including other excellent resources listed, and then we'll also refer you to a follow-up email with a list of excellent resources as well will be provided. Lastly, we do encourage you to visit the Canadian Heart Failure Society website for events planned for Heart Failure Awareness Week, and also access to heart failure resources, including new and updated materials for the general public, for people living with heart failure, and also for healthcare providers. And just a reminder that a recording of this webinar will be uploaded and available online on the following sites. And after today's webinar, a webinar evaluation will be sent out to you by email, inviting everyone to complete an evaluation, which will lead to a certificate of participation. So on behalf of Heart and Stroke Foundation and HeartLife Foundation, we wanted to extend a heartfelt thank you to, again, our presenters today, and also for everyone who took their time out of their day to expand their knowledge and also awareness of heart failure. We hope to see all of you very soon at Heart and Stroke's upcoming Stroke Month webinar in June, where we'll be focusing on optimizing cerebral venous thrombosis care and outcomes and closing the evidence to practice gap. And that will be held on June the 13th at 12 p.m. Eastern Standard Time. So thanks again, everyone, and take care, everyone. Thanks again. Take care.